Good evening, one and all, and we welcome you all to the ASCO endorsed CPOM webinar on personalized medicine in solid tumors. And a few housekeeping instructions before we start. Please ensure that the internet connectivity is good to have a seamless experience. By default, all the attendees will be in mute and listen-only mode. Attendees can also choose to ask questions by typing in the Q&A section, and this session will be recorded. So a few words about our foundation. It's called Creative Portal for Oncology Education and More, which stands for CPOM. It's a not-for-profit organization tasked with educating practicing oncologists and trainees, and a portal for increasing access to patient resources and improving awareness globally. And this particular webinar series, there were 4 of them, and this is the last webinar, and it's endorsed by the American Society of Clinical Oncology. So, and we also want to thank the sponsors for giving their educational grants. So it's Core Diagnostics, 4Base Care, Anand Diagnostics, and Dr. Lal Path Labs. So here's a list of the planning members who have put in all their efforts to for this webinar. So we have Dr. Santosh, who is the, in fact, he was the associate professor. Now he's become the professor in the Department of Medical Oncology at MS Ramaya Memorial Hospitals in Bengaluru. And Dr. Rachan Shetty, who is the consultant medical oncologist at AJ Hospitals in Mangalore. And Dr. Chandrakant, who is a senior consultant medical oncologist at Narayana Hridayalaya Hospitals in Kolkata. Dr. Poonam Maurya, and myself, I'm at Apollo Hospitals and in Bangalore, and I'm a medical oncologist. So here is the agenda for today. So we have the first talk by Dr. Vivek Subbiah on the current insights into personalized medicine and tumor agnostic markers. This will be followed by next generation sequencing transforming treatment landscape in metastatic solid cancers in India. Due to some personal emergency, Dr. Raja is not able to give his talk, but Dr. Ramya Anathakrishnan from the same team, she's also a consultant medical oncologist. She'll be delivering the talk. And then we have a very eagerly sought after case presentation by 2 oncology fellows, Dr. Nivedita Sen and Dr. Preetham Sardar, and this will be moderated by Dr. Senthil Rajappa. And finally, a few concluding remarks and summary by Dr. Santosh Kumar Devdas. So our session chairs for today, Dr. Christine Lovely. She is a physician scientist with a special interest in thoracic malignancies. Dr. Lovely's clinical practice focuses primarily on the care of patients with lung cancer. Her laboratory research is directed at understanding and developing improved therapeutic strategies for specific clinically relevant molecular subsets of lung cancer. She received her medical school training and then PhD degrees as part of the medical scientist training program at the Washington University in St. Louis, Missouri. And subsequently, she completed her internal medicine residency and medical oncology subspecialty training at the Vanderbilt University. She is the author of several peer-reviewed scientific manuscripts, and she's an active member of the American Society of Clinical Oncology, the International Association for the Study of Lung Cancer, and the American Association for Cancer Research. She is also the deputy editor for the website My Cancer Genome, a Vanderbilt-initiated, freely available website which aims to provide healthcare practitioners, patients, and advocates with up-to-date information regarding genetically informed cancer medicine. And we also have Dr. Senthil Rajappa, who is going to be the chairperson as well as the moderator for today. And he's a senior consultant in the Department of Medical Oncology at the Basav Tarak Rama Indo-American Cancer Hospital and Research Institute in Hyderabad, India. And Dr. Rajappa completed his medical oncology training at the esteemed Kidwa Institute of Oncology in Bangalore. He served as consultant in Apollo Hospitals Chennai, Apollo Hospitals Vijayawada, and also the prestigious Nizam's Institute of Medical Sciences, where he served as an assistant professor and subsequently an associate professor for 7 years prior to joining Basav Tarak Rama Institute. He's a wonderful orator, and he has delivered more than 150 lectures in national and international forums, has been a principal investigator and co-investigator in several national and international clinical trials, and he's been a peer reviewer for several national journals and international journals. And he's part of the Scientific Advisory Board and Speakers Bureau for many national and international pharmaceutical companies. and has been instrumental in starting the DNB program at his center, and he heads the program. So now we have Dr. Vivek Subbiah to give us pleasure of introducing Dr. Vivek Subbiah, uh, who is a good friend and a wonderful human being. And in fact, he serves as the chief at the early phase drug development at the Sarah Cannon Research Institute. He recently joined that center in 2023. Prior to this, he was at the University of Texas MD Anderson Cancer Center, and he was part of the Department of Investigational Cancer Therapeutics. And during his long tenure for almost 15 years at the MD Anderson Cancer Center, Dr. Subbiah held several leadership roles, including Executive Director, Medical Oncology Research, MD Anderson Cancer Network, as well as Clinical Medical Director, Division of Cancer Medicine, where he oversaw both the outpatient and the inpatient clinical care delivery operations for the Phase 1 program. Dr. Subbiah has served as the principal investigator in over 100 Phase 1, Phase 2 trials and co-investigated in over 200 clinical trials, and is known for his leadership in several first-in-human and practice-changing studies that has led to FDA approvals. And we all know about his FDA approvals, including the BRAF and RET tissue agnostic studies, and several top-notch publications, including the New England Journal of Medicine, Nature Medicine, JCO, JAMA Oncology, and the list goes on and on. Over to you, Dr. Subbiah, for your talk.
Thank you so much, Dr. Vishwanath, for the generous introduction. Before that, I think I got a message here that Dr. Lovely is joined as a panelist, and not as an attendee, not as a panelist. Someone has to promote her as a co-host so that she can join the meeting as well.
Okay.
All right, I think we got Dr. Lovely here. Perfect. Wonderful. All right, it fills my heart.
Thank you for letting me join as a panelist. Good morning.
Sorry about that, Dr. Lovely.
No problem.
Thank you. Yeah, it's a pleasure and honor to join you all. I think Dr. Lovely and I are now in the same city again, right? So I just recently moved like 2.5 months ago, but I've been traveling. It's been a pleasure and honor to meet her virtually now. Wonderful.
All right. It fills my heart with joy unspeakable to talk to you all. Current insights into personalized medicine and tumor agnostic markers. When Dr. Vishwanath called me, I said I cannot travel to India, but I'd be happy to do this virtually. And it happens to me, I'm getting older by another year today.
Happy birthday, Dr. Subbiah.
Oh, thank you so much. So in my brief agenda for today, I'll be talking about current state of drug development and precision medicine. Mainly touch down upon tumor agnostic drug development, talking about the latest tissue agnostic approval, and also what's there in the near future in terms of tumor agnostic precision medicine and why we need tumor agnostic precision medicine. Again, and then key takeaways from this. So in 2023, as we all know, battling cancer is like the story of Hercules and nine-headed Hydra. So the story goes that when Hercules cuts off one head, two heads pop up. So again, that's what we see in oncology. So we give a drug and we have two resistance mechanisms popping up. We give another drug, we have another couple of two resistance mechanisms popping up. So again, that's what we are dealing with oncology every day. For the next 10 years, Dr. Hanrahan has given us a path on what to focus on, including non-mutational epigenetic reprogramming, polymorphic microbiomes, senescent cells as hallmarks of cancer, new dimensions. So again, all scientists are going to be so busy in the next decade working on all this and how we can impact and influence cancer care by targeting all these emerging hallmarks, enabling characteristics, and new dimensions. So how did we treat patients with metastatic cancer before the next-gen sequencing era? It was a one-size-fits-all approach and a guess approach. So oncologists, we compare ourselves to astronomers, right? We call ourselves the moonshot program. We want to go to the moon. So, this on the left side, what you see is the Galileo telescope. And my 9-year-old son is gotten into astronomy, so we bought a telescope, an amateur telescope, for around $100 in Amazon Prime, and we went to Sedona and we watched the Jupiter's moons. That's how it looks. The Jupiter's moons exactly look like that, and that was using the Galileo's telescope. Right now we have the James Webb telescope. Right here you can see the telescope's first public image that shows a cluster of galaxies called SMACS 0723, which is so heavy that it warps and magnifies the light from distant galaxies and beyond. So we've come afar from Galileo's telescope to James Webb telescope. In fact, this is another image from James Webb telescope that shows a cartwheel galaxy alongside two small companion galaxies, which was created as a result of intergalactic collision. With the James Webb telescope, we are able to peer into 13.5 billion light years into the universe. Again, I cannot wrap around my head for one light year. Think about 13.5 billion light years. Astronomy has come afar. Oncology has also evolved from the light microscope to the molecular microscope. Why do I say that? Because we moved on from Anton von Leeuwenhoek's light microscope, and we have this tool called molecular microscope. Of course, we are not there as James Webb. I would say we are there in the Hubble era space in oncology. This has been enabled by what we call as Moore's law. What is Moore's law? The cost per raw megabase of DNA sequence comes down. 30 years ago, they said we cannot sequence a human genome. Then it took $3.3 billion to sequence the first human genome. Right now, we can get the sequencing done in the US for $1,000. And a colleague in Mumbai and another colleague in Singapore say that they can get it for $50. And you may all know better. And one colleague in Mumbai has promised that he's going to take it to $1, genome testing for $1 in the next decade. So if it is $1, I would say 60, 70 rupees, depending upon the conversion rates. So every patient will be getting genomically tested in a clinic near you in the next decade. This is enabled by Moore's law. Unfortunately, in drug development, we see the opposite of Moore's law. We call it the Erum's law. What is the Erum's law? This is the law of drug development. Because 30 years ago, it cost $1 billion to make 30 new drugs. Today, in 2023, November, it costs more than $1 billion to make one drug. Again, this is not sustainable. This is not practical. $1 billion for a drug. So discovering new medicines becomes more and more expensive. So how do we break the cycle of Erum's law in drug development? The advent of next-gen sequencing, so that we don't treat the right patient at the right time. We have a subset of biomarker-driven diseases where we can target with targeted therapies. Repurposing drugs. Again, if a drug is approved for one indication, the drug can be repurposed for another indication. Another area that has recently opened up is what we call as tissue agnostic drug development. That can also break the cycle of Erum's law. So these are some of the precision medicines approved in cancer. Again, this slide needs to be updated, mainly because after this publication, we had at least 10 different precision medicines being approved. Again, non-small cell lung cancer was a poster child. After that, many cancers picked up. Breast cancer, GIST, and several other cancers picked up as children of precision oncology. What is tumor agnostic treatment? It's a different way we think about drug development and cancer treatment. A tumor agnostic treatment is a drug treatment that is used to treat any type of cancer, regardless of where it originated in the body. Again, we are used to thinking about developing drugs for breast cancer, kidney cancer, prostate cancer, lung cancer, etc. A tumor agnostic treatment treats any kind of cancer as long as the cancer has a specific molecular alteration targeted by the drug. So the new era of tissue agnostic drug development and approval was, the main watershed moment was in 2017, May 23rd, 2017, when FDA approved for the first time an immunotherapy based on a genomic biomarker. So it represented a sort of marriage of genomics and immunotherapy. Why this was important? This was the first time ever in the history that a drug was approved based on a biomarker, not based on where it was located in the body. It was a tissue agnostic approval. The approval was based on a genomic biomarker. The approval was based on not a randomized clinical trial. The approval was based on retrospective and real world data. So what is this? What is microsite satellite instability? These are frequent polymorphisms in short repetitive DNA sequences. This is from a deficiency of DNA mismatched proteins. This leads to multiple frame shift and point mutations. Usually this is sporadic, from the MLH1 promoter hypermethylation. But this can also occur as a part of germline syndrome, what we call as a Lynch syndrome, which leads to thousands of somatic mutations and mutation-associated neoantigens. So this microsite instability can be detected by three methods. One is IHC for dMMR, RT-PCR, and next-gen sequencing. Again, these are the rates of MSI across tumor types. Again, from as high as 16% in endometrial cancer to as low as 2% or even less than 1% in sarcoma and renal cell cancer. So as you can see here, the response rates also vary by tumor type. You can see here endometrial cancer, the response rate is 57%. In colorectal cancer, it's 32 and 34%. Whereas unfortunately, in brain tumors, we don't know the reasons why. This is not a biomarker of response, and the objective response rate in brain tumor harboring MSI high is 0%. Again, this is from the study, keynote study of pembrolizumab with previously treated MSI high dMMR cancers in non-CRC patients. And what you see is the waterfall plot. So what is a waterfall plot for a broad audience? So waterfall plot, this shows the percentage of tumor shrinkage from baseline in tumor size. Again, you see a dotted line there. If it's less than 30%, if it's over the 30% line, we call it a response. So the objective response rate in this non-colorectal cohort with MSI high was 33.8%. And those patients above that line, we call it as progressive disease on the chart. So the next is a story of picking needles in haystacks. Why do I say that? Because NTRK fusions are seen across diverse cancers, less than 1% across many tumor types in both adult and pediatric solid tumors. Larotrectinib was approved for NTRK fusion positive adult and pediatric solid tumors, November 26, 2018. Oncologists, we always love two drugs, not one, right? So the second drug, entrectinib, was approved soon after a year later in both adult and pediatric solid tumors. NTRK fusions are found in diverse cancers, both in adult and pediatric cancers, right? From common cancers like lung cancer, breast cancer, etc., to very rare cancers like salivary gland cancer, MASC, what we call as mammary analog secretory carcinoma, secretory breast cancer. In fact, in certain tumor types like infantile fibrosarcoma, NTRK fusions are pathognomonic, and this is seen in thyroid cancer, diffuse intrinsic pontine glioma as well. In the US, right, even if it is less than 1%, right, in the US, the estimated frequency of this NTRK fusion patients are anywhere from 1,500 to 5,000 patients in the US. I think the more we test, the more we find these needles in haystacks. So the key is, these drugs are amazing. They give, yield phenomenal responses. So this rare cancer, you see anywhere from 5,000 patients, can be converted into a common cancer. Let me say how. First year, you have 5,000 patients. Second year, you have 10,000 patients. Because this drug is working, third year, you will have 15,000 patients. Fourth year, you will have 20,000 patients. So again, a rare cancer in 5 years becomes a common cancer. So this is the data of larotrectinib in NTRK fusion positive cancers. The objective response rate was 57% in the data set of 180 patients. Again, as you can see here, clearly larotrectinib is showing activity regardless of tumor type, regardless of the fusion partner for NTRK, regardless of line of therapy, regardless of age of the patients. So you can call these drugs age agnostic and tissue agnostic. So this is the data for entrectinib. Again, clearly the objective response rate you see here is 61%. And the color coding for different tumor types, right? You can see here anti-tumor activity in breast cancer, salivary gland cancer, cup, cholangiocarcinoma, CRC, thyroid. Again, clearly, these are tissue agnostic drugs. The marriage of genomics and immunotherapy story continues. Pembrolizumab was once again approved for tumor mutation burden high patients, specifically for tumor mutation burden greater than equal to 10 patients. The FDA approval was in the peak of the pandemic, June 16, 2020. Another agent, dostarlimab, was once again approved for adult dMMR positive solid tumors. The FDA approved it on 2021. So what is tumor mutational burden? Tumor mutational burden, TMB, mutations per megabase of a genomic sequence. Mutations can create neoantigens that can trigger an immune response. High TMB, as defined by the FDA approval, is typically greater than equal to 10 mutations per megabase pair, although the cutoffs vary depending upon the study, depending upon the tumor type. This may be a biomarker for immunotherapy response. High TMB is often seen in tumors with high MSI high and dMMR, but varies across MSI high tumors. As you can see here, these are the prevalence of somatic mutations across multiple tumor types. And you can clearly see here as a pattern, right? So you see melanoma, non-small cell lung cancer, small cell lung cancer. Again, immunogenic tumors have a high prevalence of some higher somatic mutations across tumor types. And the story continues. Recently, we got belzutifan. Again, this was approved in VHL positive, germline VHL positive tumors like renal cell cancer, central nervous system cancers, hemangioblastoma, pancreatic neuroendocrine tumors, others. The recent kids on the block, it's been a pleasure and honor to be involved in both of these tissue agnostic drug approvals. Dabrafenib and tremetinib for adult and pediatric patients 6 years or older with unresectable or metastatic BRAF V600 positive tumors. The FDA approved it on June 23rd, 2022. So what are BRAF mutations? BRAF mutations are seen across diverse tumor types. BRAF mutations can lead to aberrant activity of the activation of the MAP-ERK pathway. 90% of BRAF mutations are in the V600E mutation clone. It's seen in multiple tumor types. In hairy cell leukemia, it's universal. And again, some studies say that it's almost 100%. Most of the studies show that it is over 90% in hairy cell leukemia. You can see that in non-small cell lung cancer, anaplastic thyroid cancer, biliary tract cancer, among others. Again, what is the indication? Adult and pediatric patients 6 years or older with unresectable or metastatic BRAF V600E mutated positive tumors. Of course, we know that this also has, the combination has a tumor-specific approval for melanoma, anaplastic thyroid cancer, non-small cell lung cancer, and pediatric low-grade glioma. This shows the length and breadth of responses, right, with dabrafenib and tremetinib. Again, clearly, this shows that the BRAF V600E is a tissue-agnostic target, of course, with the exception of colorectal cancer. Even among colorectal cancer, you can address that by adding an EGFR inhibitor. Again, when we started doing the ROAR basket study, we saw responses in difficult to treat cancers like anaplastic thyroid cancer. As you all know, in anaplastic thyroid cancer, the median overall survival was less than 6 months. Right now, with this regimen, the median overall survival is almost 3 times that. We are seeing patients live for more than 2 years, 3 years, and I have a patient living for more than 5 years on that. The next cohort was the biliary tract cancer, again, cholangiocarcinoma. They harbor also BRAF V600 alteration, again, 53% response rates. High-grade glioma, like difficult to treat glioblastoma, 33% response rates. As you can see here, clearly, this is a tumor-agnostic target across the board. And response rates, deep response rates in low-grade glioma, 69%, colorectal cancer, GI neuroendocrine tumors, pancreatic cancer, in pediatric cancers as well. So you see a theme here. We are moving from the current era of one-size-fits-all chemotherapy to advancing to a future paradigm of customizing the right patient to the right drug at the right time. Again, we are still scratching the surface of the iceberg in tumor-agnostic drug development. So currently, we have 6 medicines approved for 7 different indications. Again, the watershed moment was May 2017. The 2 recent kids on the block are dabrafenib and selpercatinib. Let me talk about selpercatinib in the next few set of slides. Again, these have been enabled mainly by evolution of trial design, because the entire oncology field a decade or 2 decades ago was stagnant because most of the drugs were approved based on randomized controlled trials. Randomized controlled trials are really, really, really difficult to execute, and it takes time. By the time we have the results read out, sometimes the data is obsolete. So what we have, evolution of precision oncology studies, what we call as a basket study, umbrella study, platform study, and the March study. What are basket studies? These are histology independent studies wherein patients are matched to a targeted therapy regardless of histology. Umbrella study is the opposite of basket study, wherein patients with a particular tumor type are matched to arms with different targeted therapies. Again, lung cancer patient walks in the door, patient has an EGFR, gets an EGFR drug, patient has an ALK fusion, patient gets an ALK treatment, patient has harbors a RET fusion, patient gets a RET drug. Platform studies. Platform studies are a new generation of precision oncology studies that are emerging. In fact, the platform study is what gave us quick answers during the COVID pandemic. You remember the recovery study from UK for COVID-19? So 2 drugs were added, Decadron and hydroxychloroquine. In the peak of the pandemic, within 2 months of the pandemic, we knew that Decadron helped patients with COVID-19 and hydroxychloroquine was not helpful in patients with COVID-19. Again, to write a protocol, it takes 6 months. To execute, it takes 6 months. But to get answers within 2 months in a pandemic, I think that's priceless. That was because of a platform study. The future generation studies we're going to be seeing more and more are the MOT or the master observational study. These are also called real world evidence or real world data studies, right? So more on that soon. Let's talk about RET inhibitors, right? RET inhibitor from bench to bedside in precision oncology. So what are RET fusions? RET is a receptor tyrosine kinase required for normal development. Alterations in RET structure and functioning can lead to tumorigenesis. RET can be driven by 2 major mechanisms. One is a RET mutation and one is RET fusion. RET fusions are oncogenic drivers in multiple tumor types. Again, this was discovered as an oncogenic driver in 2012 in non-small cell lung cancer. And beyond that, we found it in multiple cancers. Again, in 2017, we had 2 drugs enter first in human trials within 3 years, not 10 years, 15 years as with randomized studies, but within 3 years, we got 2 drugs approved for RET fusion positive lung cancer and RET positive thyroid cancer. Again, as you can see here, RET is activated by 2 major mechanisms. RET fusions are seen in non-small cell lung cancer, again 1 to 2%. Beyond that, they are seen in pancreatic cancer, colorectal cancer, salivary gland cancer, among others. RET mutations, right? RET mutations, you need to think about the differences between fusion and mutation. Fusion is gene rearrangement or when 2 genes fuse together. Mutations are events in the single gene. So RET mutations are driver events in medullary thyroid cancer. It can be sporadic or hereditary, but whereas RET fusions are oncogenic driver events across multiple cancers. Based on the data set from the selpercatinib study that was published in the New England Journal of Medicine, in 2020, we were able to secure a US FDA approval, an accelerated US FDA approval. So this shows the tumor agnostic activity of selpercatinib with patients with RET positive cancers. Again, clearly, you can see that selpercatinib is tissue agnostic, meaning this is active regardless of type of tumor, pancreatic cancer, colon cancer, sarcoma, unknown primary, carcinoid, salivary gland cancer, among others. You can see here, these are waterfall plots. Pancreatic cancer. Again, 100% tumor reduction in pancreatic cancer. Again, these are some of the stories that keep early phase investigator up and in the morning and coming to clinic. Behind every waterfall plot, there is a patient story behind that. And this is that same patient with the waterfall plot, 100% shrinkage. This is a patient with pancreatic cancer. This is written a book, like a needle in a haystack. Of course, RET fusions are less than 1% across multiple cancers. Again, when she was sent to my clinic, she progressed on standard lines of therapy. Unfortunately, with pancreatic cancer, there was not many treatment options beyond the second and third lines, FOLFIRINOX, FOLFOX, etc. And she had ascites, she had hair loss, and we did sequencing. We found red fusions, and she said that she will start treatment in 2 weeks. She wants to wait because she wants to get married, and then she'll come back in 2 weeks. I said, no, you start today. You start today and tomorrow. You will be fine for your wedding. So again, we started the treatment a day after she saw me. 2 weeks later, she got up from wheelchair. Her ascites vanished, and she took off her wig because she started growing some hair. Her performance status from 3 came down to 1 or even 0, and she danced in her wedding. Again, these are the stories that keep us awake. She's now almost 5 years out, doing really well. Again, red fusion in pancreatic cancer, right? Needle in haystack. Another drug, pralsetinib, was also, we showed data across as a tissue agnostic target. This was the most recent publication in Nature Medicine showing that pralsetinib is also a tissue agnostic target. Again, there are adverse events with red positive tumors, right? We see nausea, diarrhea, constipation sometimes, and hypersensitivity rash, especially patients who come off immunotherapy. So in summary, you see histology agnostic biomarkers for targeted therapy. BRAF, RET, and NTRK are now approved. Each targeted agent has a unique profile that we all should be aware of. So we have a new era of cancer research. So when we find the right patients who harbor the right mutations or the biomarkers, and those patients that have the right target are matched to a right drug, we see a clear benefit. And that leads to an FDA approval. So drugs are based on biomarkers, not on cancer types. So you may ask, what's next, right? As I said, we are still scratching the surface of tissue agnostic drug approvals. You see, HER2. HER2 is one of the most common, alterations by IHC in breast cancer, right? So we see HER2 across the board in bladder cancer, cervical cancer, lung cancer, breast cancer, etc. And there was this data that was shown at ASCO with Enhertu, trastuzumab deruxtecan, and HER2 expressing solid tumors. Clearly, this is a tissue agnostic drug, maybe with the exception of pancreatic cancer. 4% versus cervical cancer of 50%, endometrial cancer 57%. Another drug called zenocutuzumab in patients with NRG fusions. Again, NRG1 fusions are similar to NTRK or RET fusions, less than 1% across multiple tumor types. Again, you see the waterfall plot. Clearly, NRG fusions are tissue agnostic targets. KRAS G12C is a tissue agnostic target. Again, this data is shown in patients other than non-small cell lung cancer or colorectal cancer. So I've been just talking about genomics and maybe immunology, right? So this is the story of 6 blind scientists and cancer drug development. You all know the story of 6 blind scientists and the elephant. So you see here the 6 blind scientists here, or I would say even 6 blind doctors, right? Gender balanced doctors, of course, thinking about oncology, right? That this is only genomics, this is only immunogenomics, etc. But we need a comprehensive molecular portrait of every patient walking in the door. I think the next 2 decades, we're going to learn more on metabolomics, transcriptomics, microbiomics, proteomics, and beyond. One of the main challenges in precision oncology is, you see here, these are the precision oncology trials. Most of the world, they are only done across the sides of the Atlantic. Most of the world are not part of these precision medicine studies. And even China and Australia only recently got added to this map. Latin America, Africa, and many, many countries are not a part of precision oncology registration studies. We need to think globally and act locally. The timeline of drug development, 10 to 15 years, is unsustainable. We need to cut short the phases of drug development. I think I'm fervently hopeful that AI technology, right, it is with the AlphaFold, it's dreaming about new proteins, new drugs that we couldn't even think of. So again, basic science has taken leaps and bounds. I'm sure the clinical trial machine infrastructure, which we still use fax machines and binders, can take a lot from AI evolution and revolution, so that we can cut short the phases of drug development. So still in 2023, we do not have all the data for the patient sitting right in front of us. We provide very shallow medicine. We need to yearn to make sure that we can deliver deep medicine to the patient sitting in front of us. We need to have all the data, all the real world medical literature, so that we can assimilate and provide AI-based deep precision medicine to our patients. Again, I asked ChatGPT, and together with ChatGPT, I collaborated to write this, I would say, the beginning of a Shakespearean sonnet. As you know, it's 14 lines, but this is just 8 lines. The next 6 lines are still in the works, because precision oncology and tumor agnostic precision medicine are also still in the works. It's unfinished. In future's light, a beacon bright shall gleam. Tumor agnostic medicine's bold dream, no more confined to cells of one cruel name, but tailored cures each patient's path to claim. With scientists' word and data's steadfast hand, we'll conquer cancers as we understand the intricate dance of genes and mystery, unlocking healing's boundless tapestry. What is the key takeaway? So we have 6 medicines approved for 7 indications and more coming in the next decade. To ensure that patients with solid tumors who could benefit from tissue agnostic therapies, it'll be essential to identify biomarkers by comprehensive genomic testing. We cannot guess, we can just do NGS, right? We need to pick these needles in haystacks. How can we pick these needles in haystacks? Either we need to have a magnet or burn the haystack, right? We thank all the patients and their caregivers for their participation in all the studies, all the investigator staff, and thank you for the organizers for inviting me to give this virtual talk. I'm available on X, former Twitter, and this is my email if you need to reach out to me. Happy to take in any questions. Thank you so much.
Thank you, Dr. Vivek Subbiah, for that wonderful talk, and wishing you a happy birthday again from all of us.
Oh, thank you.
And Dr. So the next talk is going to be by Dr. Ramya Anathakrishnan, and she is currently working as a consultant in the Department of Medical Oncology at Apollo Cancer Center in Chennai, and she also works at the Apollo Proton Cancer Center. And she completed her medical school training and her internal medicine residency from the Government Kilpauk Medical College in Chennai. And after completing a fellowship in medical oncology from the Apollo Cancer Center in Chennai, she's currently practicing at the same center since 2021. And her area of interest apparently is precision oncology. And she's here to give a talk on next generation sequencing transforming treatment landscape in metastatic cancers in India. Over to you, Dr. Ramya.
Thank you, Dr. Vishwanath, for having me here. And it was really enlightening to hear Dr. Vivek Subbiah's talk. Thanks for having me here. So the topic for me is going to be NGS transforming treatment landscapes in metastatic cancers in India. See, the whole treatment in oncology has evolved the last century, especially in the last couple of decades. The treatment opportunities and treatment patterns have changed a lot in oncology, as Dr. Vivek had presented earlier. And we are in the current era of tumor agnostic therapies more than tumor histology-based therapies. Just as the treatment has evolved, the diagnostic part of oncology has also evolved a lot, right? From 1970s, when we started with Sanger sequencing, we're right now into the era of metabolomics, proteomics, transcriptomics, and whatnot, the third generation of sequencing also. We had this publication from India. So what is the role of comprehensive genomic profiling in India, and how much has it impacted Indian patients? This was a paper that looked at it, which said the numbers were as low as 4%. Only 4% of patients actually who underwent CGP benefited from treatment targeted to CGP, but we have a different story to tell here actually. Bringing a few cases from the archives as old as 2001. In those days, when we found a lung malignancy, Sir had applied for gefitinib on compassionate basis, and that showed a very good response as seen on the X-ray. And this goes same for the second patient also. In 2003, gefitinib showed an excellent response in the second patient also. The same goes to erlotinib. These are very old, from 2007. So apologies for the quality of the imaging, but based on clinical profiling, this patient was put on erlotinib, and he showed an amazing response, a busy executive. He went on, his quality of life was excellent, and targeted therapy started from then. Actually, the concept of targeted therapy started in the late 1980s when HER2 was identified in breast, and then came imatinib, gefitinib, and then rest is history. But since the 2009 publication in NEJM brought out the importance of personalized medicine, especially targeting EGFR in lung cancer. So what is the impact of this NGS in therapy in India, in our practice, is what I'm going to throw some light on. Let's see first few common genomic alterations. We're all so used to erlotinib, gefitinib, osimertinib, and those responses are established and well known for. Comes in the same line are RET fusions. So this was a young lady. She had a RET fusion. It was a lung malignancy. Did not respond to any of the conventional chemotherapy options. But the moment pralsetinib was given, pralsetinib had to be obtained on compassionate basis by application. That time the drug was not available for us. And the tumor just literally melted with the therapy. She's still on it and continuing on it, continuing to be on response also. The same goes to the second patient, who's a 56-year-old female, had a metastatic lung with bone secondaries at presentation. Initially started with conventional chemo, pemetrexed and carboplatin. There was not a great response, or rather progression even in few areas. Her NGS picked up the classical KIF5B RET fusion. We put her on selpercatinib. It was not available. We had to import it. And then the PET showed an excellent response. Within 3 months, all her symptoms of cough, breathlessness settled. And she's still continuing to show response to selpercatinib and to till date. The third common alteration that we see is a high PD-L1. We are used to reflex testing of PD-L1 in lung is very normal and very common. And this was again a female patient, 56-year-old, poorly differentiated carcinoma of the lung with an extremely high PD-L1 of 95%, did not tolerate chemo. And we went ahead with single agent pembrolizumab. She has now completed 42 doses and continues to be in remission. Beyond remission, her quality of life has been excellent. All the patients presented so far have had a very good quality of life. They're able to do their regular activities and still continuing to enjoy the response that we see with the targeted therapies. The fourth and the last common agnostic approval that we spoke about, the MSI high solid malignancies, where pembrolizumab was approved in 2017. This was a 32-year-old male, actually diagnosed in 2014 with a metastatic colon. He received all possible treatments, FOLFOX, FOLFIRINOX, bevacizumab. He even underwent a surgery and a high PEG. But in 2018, he continued to progress. And that is the time we had started him on pembrolizumab. His peritoneal lesions regressed. He could take up to 32 doses of pembrolizumab, beyond which we had kept him on follow-up. He continues to be in CR till date. So off treatment for more than 2 years and still in CR, and that is the response that we see with an MSI high tumor to pembrolizumab. Now, these common responses, most of us would have seen in our clinics. This have become a very common feature in our regular practice. Now, I'm going to move on to a little bit of uncommon alterations and how we came to a conclusion of treating them with what targets we chose. So I'll be talking about 3 metastatic non-small cell lung cancers. It was the first case is a 64-year-old male who had a HER2 amplification and did not show any response to conventional pemetrexed, carboplatin, or docetaxel, because that is the first line agents that we chose. He continued to progress on docetaxel also. So this is the April 2021. The scan here shows the image at the end of pemetrexed and carboplatin. Then he was shifted to docetaxel. Even in July 2021, the scans continued to worsen. He symptomatically began to worsen. Based on the HER2 amplification and literature search, we had started him on afatinib. And within 3 months, you can see the images showing a very good response. He continues to be on response, and till date, we saw him in clinic as early as 2 days back, and he's flying off to US to visit his grandchildren. So that is the power of precision medicine. This prognosis would not have been possible in him if we had not chased the HER2 amplification. Exon 20 insertions in EGFR were rare at one point in time, but now the more and more that we do NGS, we are picking up the alteration more commonly. And with the drug available, amivantamab, we have all seen responses in the second line. But what I'm going to present is the next patient, a 60-year-old male who was diagnosed with an adenocarcinoma in lung, had an asymptomatic brain mets, which we picked up on MRI screening. He was found to have an EGFR exon 20 insertion. He was treatment naive. PD-L1 was at 15%. We were aware of the Papillon trial that was going on, and we also knew that there is already a target there. Definitely using a targeted therapy against it would bring about a better response than using chemo alone. So after explained consent, we had started him on amivantamab plus pemetrexed and carboplatin. And the results of Papillon trial came as early as interim results came as early as a couple of months back. He showed an excellent response to the PET. Now, this can always be argued as a part of chemo response, but the interesting part was the intracranial disease. He showed a complete response in the intracranial component of the disease also, which might not be very expected with a heavy molecule like amivantamab, but he still showed a CR. He still continues to be in CR, almost a year on maintenance of amivantamab, and he still continues to be in CR. This was the interesting segment of this case. The third unusual, uncommon alteration that we saw in lung is he was a 50-year-old male, again, lung with effusion, metastatic disease, did not respond to the conventional chemo, progressed on the effusion part. He had to undergo a VATS thoracotomy, decortication and all, post which he came to us. We had done an NGS with Foundation 1 that picked up an EGFR kinase domain duplication. Now, this is very, very rare. We all know it's just less than about 0.12% of all NSCLCs, and there are quite very few papers that talk about targeting an EGFR KDD either with an upfront TKI like afatinib or osimertinib, or combinations with cetuximab plus afatinib because of the kinase domain duplication part. Afatinib he could not tolerate. He had difficulty in about two weeks, and we shifted to osimertinib, and it's almost over a year he's on osimertinib and still continues to show response. And beyond the response, his quality of life is excellent. He was not able to go to work. He was almost at home or continuously. He was not able to eat. And with treatment and with response being established for the disease, his quality of life has improved, and he's gone back to his normal routine like anybody else. Now, moving on to the next type of malignancy. I'm picking up this pancreatic cancer only because of the rarity in the NGS. Now, this was a 80-year-old male who presented with a pancreatic mass. It was completely encasing the common hepatic artery. Came in very sick, unwell, stabilized, and the NGS picked up a very high TMB. As presented earlier, TMB being high in pancreas is very, very, very less. It's close to 1%. And we saw a high TMB of 33 here. He was started with conventional gem nab-paclitaxel based therapy, but he could not tolerate it. So we shifted to pembrolizumab. We started him on single agent pembrolizumab. He was also incidentally found to have a coexisting prostate cancer that was a low-risk disease. He responded excellently well to the single agent pembrolizumab to the extent that the 5-centimeter lesion regressed and became to a size of 1 centimeter. We could do a consolidation radiation to both the pancreatic residual as well as the prostate. And this all happened about 2 years back in May of 2021. He was kept on continuous follow-up. We also employed CTC to make sure that he's not showing any early relapse. Till date, he is in remission, fully fit, doing all his activities, and off treatment only on follow-up. Now, moving on to the next type of cancer, ovarian disease. I'll be talking about two cases here. This ovarian disease patient was diagnosed in March of 2017. She underwent conventional therapy, but then had a relapse, had to undergo a secondary cytoreduction in June of 2018. Again, a high-grade serous carcinoma, but vehemently opposed chemo. The sequencing done at that time picked up few amplifications. What caught our eye was the CDK4 amplification because the drug was available at that time. We were already using it in breast. We started her on palbociclib and letrozole, and she's continued to be in CR till now, both biochemically as well as clinically. This was we did an imaging as recently as 3-4 months back also. She's completely in CR. The second ovarian malignancy patient had received multiple lines of treatment. When she came to us, we did a sequencing with Foundation, and that had picked up a very rare PDL2 mutation. And when we targeted with pembrolizumab, she had a complete CR of the disease, and still continues to be doing well. So these two alterations in ovarian cancer was quite rare, and the response was significant. And as mentioned, the next alteration that we saw, the NTRK alteration in sarcoma, we picked up, this was a young lady, multiple lines of treatment done for sarcoma. Sequencing picked up the NTRK fusion, and treatment with entrectinib changed the course of the disease. She became symptomatically much better, radiologically better, symptomatically better, and is clinically doing well. And so these are the response images for the entrectinib patient also. Moving on to the next cancer type that I have an example here is carcinoma of the breast. Now, this was a very low hormone positive, HER2 negative localized disease to begin with. Went on to develop hormonal resistance, and she received CDK4/6 inhibitors, found to have a PIK3CA, received alpelisib also. Beyond that, on progression, she did not respond to either eribulin or sacituzumab. So we had done a rebiopsy at that time. Initially, her HER2 on the IHC was 0, so we had not thought about deruxtecan at that point in time. But the repeat biopsy picked up the HER2 to be equivocal and 2+. So she was started on trastuzumab deruxtecan. She's completed her 10 cycles now, and all the liver lesions have resolved. Symptomatically, she is much, much better. Quality of life is much better when we shifted our treatment towards HER2 targeted therapies. Now, having seen so many alterations in our patients, we decided to compile our data. So the next couple of slides are going to be the data from our own institute and our own patients. This is over the previous maybe 3 to 4 years of data we have retrospectively collected. In a total of 478 NGS, we figured out that each of these alterations contributed to about 20. EGFR was the most common, 23 to 20%. And among the whole exome sequencing, we had a lot of colorectal cancers. We could see a gender-wide distribution among the cancers also. We had a special interest in looking at KRAS, especially when KRAS G12D. We were actually chasing a patient with the KRAS G12D pancreatic cancer for enrollment into a trial. There was a trial ongoing in Shanghai, but they did not allow any patient other than from mainland China to enroll. And MRTX0033 was not yet into trial at that point in time. This was early of 2023. So at that time, when we looked at our data of KRAS alterations, we could find that KRAS G12D, C, and V were the most common that we found. We had about 80 alterations among the 400 patients. And G12D, G12B, and C were the most common of these. We decided to see whether there are any organ-specific distribution of these. And again, the most common that we saw was in lung and colorectal, contributing to 40 and 33% of all the KRAS alterations. Now, from a time of very traditional medicine, from the era of radiation, surgery, chemotherapy, we have just moved towards an era of personalized oncological care, where we are looking at genetic alterations, specific mutations, amplifications, trying to tailor the treatment depending on what story the gene says for that particular patient. So our postgraduate research has also changed towards looking at, these are the papers that are in the pipeline. We are trying to look at the following questions in the data that I presented above to see whether we are getting any meaningful compilation out of that. And beyond this, as Dr. Vivek mentioned, beyond genomics, we are now going into the era of transcriptomics, proteomics, and metabolomics. And I think it's wonderful to be in this era, which is rapidly developing, and it's very promising also. Thank you.
Yeah, thank you, Dr. Ramya, for your wonderful talk. I request Dr. Lovely to kind of summarize both the talks before we move on to the case discussion.
Yes. Hi, everyone. Can you hear me okay?
Yes, ma'am.
Yeah. So I apologize. I got kicked off the Zoom. I'm sorry about that. So going back to Dr. Subbiah's talk, I think you can all see, and we all experience in our day-to-day medical practices, the beauty and the complexity of precision medicine and oncology, and this is the reality of our day-to-day practices. As you can see, I'm in clinic this morning, and so I want to just summarize a couple of opportunities and a couple of challenges in precision medicine moving forward. And some of the opportunities right now, we are just talking about single markers, and you just heard many of them: EGFR, HER2, KRAS, PD-L1, genomic markers, and protein-based markers. That is truly the tip of the iceberg, as Dr. Subbiah articulated. In the future, we are going to be overlaying multiple markers. Remember, we are genotyping hundreds of markers at the same time. And so we are really, right now, just doing one marker, one drug at the same time. But the future is multiple markers to help us in this complexity of the cancer genome and the cancer proteome to say, we're going to synthesize all this multi-omic data, genomic data, transcriptomic data, proteomic data. Oh, can you hear me? Sorry, I thought I got locked out again. Genomic data, transcriptomic data, proteomic data, metabolomic data to say, how do we make our best treatment decisions for our patients? So it's going to get increasingly complicated, which is both beautiful but difficult. And I'll get to the challenges in a moment. So opportunities, multiple markers, moving beyond one marker to multiple. And I'll give you a simple example. Moving beyond EGFR mutations alone in lung cancer to EGFR P53, EGFR PIK3CA, EGFR P10. The second opportunity is longitudinal assessment of markers. So right now we're largely doing markers at the time of diagnosis or at the time of resistance to a therapy. But the truth is, in the future, what we will be doing is an evolutionary trajectory of the cancer. We will be looking at markers using analytics throughout the tumor's evolution, whether that be in blood, urine, multiple different analytes, to understand in more real time what is happening at the genomic level as the tumor changes in the setting of our therapy. And we're already starting to see this intercalate into our clinical practice with the use of ctDNA, both genotyping assays and MRD assays coming into our clinical practice. So this is, again, going to really advance the field to understand tumor evolution in a more real-time way, but add to the complexity of our clinical practices. And then the third opportunity that's going to come into the future that I want to just briefly comment on is germline assessments. So right now we're largely talking about somatic testing of tumors, but overlaying in the future, it's not just what's happening in the tumor genome, but what's also happening in the host, in the patient, that's influencing the development of the tumor and the response to therapy. And so those three, I'd say, opportunities and being forward thinking, and these are happening right now, but we'll explain in the future. Multiple markers, evolutionary tracking of the tumor with longitudinal genomic assessments, and germline assessments of the tumor. Our major challenges right now, and I'll just be brief in these comments, are number one, we've had tremendous progress in innovation. We have technologies, whole genome sequencing, whole exome sequencing, whole transcriptome sequencing, metabolomics, proteomics. We have sophisticated ways to look at the tumor. That's fantastic. I agree with multiple speakers' comments that these technologies will get cheaper and cheaper. But just because they're getting cheaper doesn't mean we will be able to use them in a nimble way in the clinic. So we have to match the innovation with the implementation. And I think one major, from my perspective, what I see is a real divide between the innovation driving the technology, our ability to acquire data, and our ability to actually bring that data to patients. And so we want to bring advances in cancer care to patients in a most equitable fashion possible. So I practice in Nashville, Tennessee, as does Dr. Subbiah right now, which is a big city, but there's a lot of rural areas around us. So if you go 1 or 2 hours away from where I live, it's very rural. And what we want to make sure we do is be able to distribute cancer care locally and globally so that no matter where you're living, you have access to state-of-the-art cancer care. And so we have to match the innovation, the technology development, with our ability to implement that care so that no matter where you live, you have access to sophisticated genomic testing for your tumor. And I would say another major challenge as we think about how do we drive cancer care forward is our workforce. And so how do we actually develop a group of cancer care professionals who are deeply committed to taking care of patients who also understand the complexities of genomic medicine, because this is really an evolving, a rapidly evolving field that's going to overlay multiple areas of cancer science that we need to think about. How do we actually address this workforce? So I will say, at a high level, those are my comments. I'll be very interested to jump into the cases and have some discussion around that. I think you can see across the cases that were presented in multiple different cancer types, there's a lot of depth of discussion we could go into. I'm happy to jump off the conversation with the cases. What would you suggest in terms of how you would like to lead into the discussion for the cases?
Thank you, Dr. Lovely, for those valuable comments. So shifting gears, let's go to the case discussion. And we have Dr. Senthil Rajappa, who is the Director of Medical Oncology at Basav Tarak Rama Hospital in Hyderabad, who will be moderating the session. And we have two case presenters. So we can start with the first case, Dr. Nivedita Sen, who will be presenting the first case. Over to you, Dr. Nivedita. So after the two cases, and Dr. Senthil can take over and moderate the case discussion.
So Vishwanath, should we do one after the other? So one case and some discussion,
Sure,
and then
we can do that.
Case. So
we can do that.
So that's easier, right?
Sure.
And how much time do we have?
We have 30 minutes for both the cases put together.
Lovely. Okay.
Good evening, my respected teachers. I am Dr. Pritam Kumar Sardar. I am a DRNB Medical Oncology resident, Narayan Super Specialty Hospital, Kolkata. Today, my topic of discussion is rate mutated lung cancer and what we are treating in our hospital. So, a 54-year-old lady with no comorbidities presented to us in March 2018 with a 3-month history of breathlessness and cough. She had no fever, had weight loss by 3 to 4 kg. She was ECOG performance status was 2. She was mildly pale. She had tachycardia, tachypnea with a oxygen saturation was 88% in room air. Respiratory system examined revealed absent breath sounds in the right hemithorax with a dull percussion note. Her hematological and biochemical parameters were acceptable. An intercostal drain was inserted, which drained 1.5 liters of hemorrhagic fluid. Cytology came to be adenocarcinoma. A biopsy from pleural nodule revealed adenocarcinoma with acinar growth pattern. EGFR by polymerase chain reaction was negative. ALK by immunohistochemistry was negative. ROS by immunohistochemistry was negative, and PDL1 by SP263, that is Ventana, is negative. She then received 4 cycles of pemetrexed plus carboplatin as first-line treatment, after which she had a partial response. She then completed 18 cycles of pemetrexed maintenance. Disease-free interval was 1 year, 4 months. She then developed disease progression in July 2019 with development of abdominal pain. This is his baseline CT scan, which showed left lower fissure nodule, right hydropneumothorax, and omental deposit. This is corresponding PET CT images, which showed right lower lobe mass, pleural deposit, moderate pleural effusion, right hilar nodes, and few omental nodules. He then started on second-line treatment with docetaxel and ramucirumab. Docetaxel at the rate of 75 mg per meter square and ramucirumab at a dose of 10 mg per kg every 3 weeks. Post 6 cycles dosi ramucirumab, patient was on PR, and post 6 cycles ramucirumab maintenance, patient was on PR. The major treatment-related adverse events was grade 2 hypertension, grade 1 proteinuria, pedal edema, grade 1 nail changes, alopecia, grade 2 fatigue, and grade 2 anemia. He then has disease progression with increase in omental disease. Peripheral blood for liquid biopsy by NGS suggestive of rate mutation. This is his NGS report. This report reads total 27 fusion with gain of function. Fusion in chromosome 10. So this is FDA approved drugs in NSCLC, that is a selpercatinib and tralcetinib. Another few drugs, that is multityrosine kinase inhibitor, are also investigated in rate fusion NSCLC, that is cabozantinib, vondatinib, alectinib, ponatinib, sorafenib, sunitinib. Gene summary: red gene encodes a transmembrane receptor and a membrane of tyrosine protein kinase family of proteins, binding of ligands such as gDNA, that is glial cell line derived neutropenic factor, and other related proteins to the encoded receptor stimulates receptor dimerization and activation of downstream signaling pathways that play a role in cell differentiation, growth, migration, and survival. She was started on sulfatinib from March 2022. CT scan done after 1 month, suggestive of near complete response. He had a diarrhea and hypertension. This is a new present CT scan which shows resolution of the omental deposit and the lung mass. Her quality of life is well preserved. She is able to go to office right now. Hairs have regrown back. A residual grade 1 peripheral neuropathy is persisting. She is continued on Kairamja maintenance, has completed 1.5 years from the start of the regimen. Thank you.
Thank you so much for that lovely presentation. That's a very nice case, taking us through the journey of a patient with a RET fusion. I'm glad you were able to access sulfatinib and the patient is doing well. So I will, yeah. Vishwanath is, I know Dr. Subbiah is here. Dr. Christine had to leave because she had some patient-related issues. So maybe I will also ask some questions from an Indian perspective to Dr. Ramya or Chandrakant, if all of you are fine with it, including you. That is okay, because while we learn, we have our own set of problems, right? So we have 10 minutes to go, and then we'll try to do as much as we can. Dr. Subbiah, I have to start with you because you're the RET specialist and the draft specialist today. We all have our handfuls of patients, but nothing compared to your experience. Is an RNA NGS better to pick up a RET fusion, Dr. Subbiah? Because generally the way we are taught and the way we've read is that for fusions, RNA is better compared to DNA or any of the other methods. What are your thoughts?
I think that's a great question. So for RET fusions, interestingly, I think DNA can still pick up RET fusions with DNA. We are able to pick up most of the RET fusions, like at least known partners with the DNA-based NGS methods. And RNA is probably more specific if DNA is negative. There have been studies that show that when DNA is negative, then you reflex to RNA-based NGS, then they are able to pick up fusions. But we are able to pick up most of these with DNA-based NGS testing, both from somatic testing and also by liquid-based biopsies.
Excellent. So that's right. So the specificity and the sensitivity seem to be a trifle higher, but the incremental benefit doesn't seem to be as much as we would all think.
And again, I don't know about the cost in India, right? So what reflex testing or RNA versus DNA-based NGS. But most of this time, we can get the result of RET fusions with just DNA-based NGS.
Right. So, Chandrakant, you treated your patient with pemetrexed and platinum. That's what all of us do, because whenever you try to get sulfatinib on compassionate basis, they will say, has your patient progressed on the first line treatment? Because that's the approval for sulfatinib before this tissue agnostic approval. So have you had other patients with RET fusion, and did they do as well as your patient that was presented? Because you showed a PFS of 16 months, while Dr. Ramya showed that their patient did not respond very well. So what is your experience with the handfuls of patients that all of us have had with RET fusion? I can also share my experience after you do. Chandrakant or Vishwanath, any one of them?
Yes, sir. So I'm there, sir. So that is true, sir. So we are presenting a case as a selection bias. We are presenting good cases, and with a bad case, we don't present cases. So we had a met and a red. We gave cabozantinib for this patient. Problem is we give it only in the last line. We do this desperate test in the last line.
Okay.
So they didn't do that well. Like they didn't have access to self-architecture. For this patient, the patient was dedicated enough to pursue it. So we give cabozantinib. We have tried, sir. It has not done that well. I agree. We should be doing these in the early line setting, but unfortunately, we end up doing the patient is in the borderline performance status, the desperate, and cabo is not that good as self-architecture. And this is This is a very
Absolutely.
selection bias. We cannot take this to practice.
I know. The reason why I'm asking is I've got 3 or 4 patients with red fusion who are on chemo, and good for those patients. They don't seem to be progressing, and that's what we've seen in the libretto also. If you look at the PFS for pemetrexed, platinum, and immunotherapy, I'll ask Dr. Subbiah about the role of immunotherapy there. Was it worthwhile adding the third drug in patients with red fused cancers? The median PFS seems to be the best among almost all the driver mutated cancers. It's 11.5 months. All of us used to think that ALK positivity gives you a lot of super sensitivity to chemo, but this is 11.5 months. Dr. Subbiah, is that surprising to you, or is it something very unique about red fused cancers that make them also quite sensitive to chemo? Because the median PFS in an unselected set of patients with pemetrexed carboplatin is about 5 months, 6 months. We are seeing 11.5 months in the libretto 431, if I'm not mistaken, that was presented in ESMO. Better than the ALK rearranged patients. So what is it that makes these patients quite sensitive to chemo? Of course, sulfatinib is far ahead. It's 24 months, but chemo is not bad.
No, absolutely. I think you're 100% right, because for reasons, right, these patients tend to be non-smokers, and pemetrexed, again, even before the advent of sulfatinib, pemetrexed-based therapies were had differential benefit, specifically in red positive patients and even EGFR patients. We don't know why. That's a great question. We don't know why. Clinically, we know this data, right?
Yes.
So, we still don't know why. Maybe we can, we need to think back and see why red fusions are vulnerable to pemetrexed-based therapy. We don't know, right? Maybe there is some folate pathway that is given. So that opens up doors for future therapies, combination therapies with sulfatinib and pemetrexed, so that we don't, we can extend the PFS from sulfatinib or either agents, right? At the same time, we can prevent the resistance mechanisms from forming. So again, that's a unique observation. We've seen that even before the advent of sulfatinib. And one more thing I just wanted to mention about sulfatinib is, when we did the original registration study, right, the original registration study in the US. So giving you a brief history on the libretto.
Sure,
it was
please.
the libretto 001. It was the first in human phase 1 study. I remember enrolling the first person in the universe on the red fusion. And after 3 days, I called the company. I said, this is a drug. This is a drug. This is a real drug, because I do phase 1 studies. Right? Most of the time, the drugs don't work. Like 95% drugs fail. And I'm like, wow, this was like a magic drug. And I'm like, first, again, with all this time, I say one patient is an anecdote, right? Usually we see that first time we see some patients respond, and then the drug fizzles out. 2 patients, okay, it's a case series. After 3 patients,
it's evidence.
I said, okay, this is a drug. This is definite. This is the FDA approved drug. We need to design the study. So we designed the study. We amended the study, a 20-patient study, and now it became a 1,000-patient study, right, with amendments. Yes. And we enrolled only relapsed refractory patients in the study first, right? Post pemetrexed, post platinum, post immunotherapy. Yes. The response rate was 68%. And then, because the drug was so well, we amended the protocol to include, treatment naive patients, and the response rate was as high as 90% in those patients, right, who were treatment naive. And again, that the data set of 144 patients, we were able to secure an accelerated approval in the US in May 2020. And then subsequently, last year, it got a full approval, full approval based on that study. They based on a single arm study. FDA did not want even a randomized study. They just had more patients on the single arm study, and it was approved in a line agnostic manner in lung cancer. Again, as long as the patient presents with red fusion, the drug was approved first line, second line, third line, fourth line, because that's how the study was designed. We had patients in treatment naive setting. We had patients who presented to us after second line, third line, fourth line. In Japan, there was a patient after 15 lines. I don't know how Japan, they have 15 lines.
You always see that in Japanese patients.
I don't have 15 lines in these patients, but having said that, maybe the patient did well because the patient had a better prognostic impact for us.
Yes.
Right? We don't know, right?
Yes.
And they respond like Hodgkin's, right? Responds to anything. Right? Like red patients. that probably particular patient had a genotype, phenotype that responds to anything. So having said that, you asked a question about immunotherapy, right? Immunotherapy as monotherapy is not beneficial for Rett patients.
Right.
I think it's a combination with pemetrexed and chemotherapy. So what we did was, when the trial was ongoing, one of my former fellows, who's a lung cancer faculty now, in fact, she's from Bangalore originally, before moving to the US. She looked into, Dr. Hegde, Aparna Hegde, looked into all the patients, with Rett positive tumors that were enrolled or received immunotherapy. Again, we clearly, she showed that, patients do not benefit from immunotherapy.
Right.
It's only the combination with chemotherapy. I think if there is a Rett fusion, again, there might be some outliers that respond to immunotherapy, one or two anecdotal cases, but majority of the patients do not benefit from immunotherapy. And again, I still don't know the contribution of immunotherapy.
Absolutely. Even in the pemetrexed combination, pemetrexed carboplatin combination. Right, because Dr. Benjamin Bess in his beautiful discussion at the ESMO pointed out exactly what you are just telling me, that it's probably a waste of resources to have had 80% of patients on the Libretto study take immune checkpoint inhibitor along with pemetrexed and carboplatin, was his thought, which is exactly what you're saying. 80% had immune checkpoint inhibitor along with the first line chemotherapy. The next question, Dr. Subbiah, is two things. One is just the fusion partner matter. That's something that we initially thought in ALK the fusion partner did not matter, but as we went ahead, we know the V1 is different, V3 is different. Is that the case in Rett also? Are we learning more about the fusion partners? Is the KIP different from the CCD? What are your thoughts based on your experience again?
Oh, that's a great question. So we are learning now.
Right.
We know that Rett is a tissue agnostic or a target regardless of fusions, but the duration of response, the PFS, we are learning now.
Right.
As when the studies mature. Again, we saw some hints of this before the selpercatinib. There was a drug called RxDX 109 or 105. Right. So that drug clearly showed only 2 patients that responded to CCD6 and no patients with KIF5B responded. But when the selpercatinib and pralsetinib data read out, every patient responded with regardless of KIF5B or CCD6. What we are seeing more and more is patients with CCD6 have a better prognostic impact, a predictive impact with selpercatinib. Again, the numbers are very, very low. Again, they do KIF5B definitely responds, and we are still scratching our head on understanding the reasons why it is that case. Again, they may require maybe because of brain mets, maybe because of other reasons. So we are still looking into those causes. Right now, clinical data, there is not much differential, like ALK. But I think we are seeing early hints of things because these are new drugs. Only when we get these drugs to the real world, we find so many fusion partners, right, that were not even displayed in the clinical trial.
Correct.
So again, clinical trial are done in niche boutique academic centers where they have a panel of set genes. So again, when we take it to the real world, you see more partners. So again, every patient you treat with Rett, if it is positive or negative, I think that's a case. If it is negative, that should be a case report. If it's positive, that should be a case report, right? I think that's why we want, we encourage our young faculty to publish more and more positive or negative data so that, we can assimilate all the data.
Lovely. One last, 2 things. One is more from a trial development standpoint. The second is your thoughts on selpercatinib versus pralsetinib, because pralsetinib is kind of now stuck in terms of its development, because I believe Roche has handed it over back to its parent company because it's not been able to develop it. And again, Dr. Bess, in his very nice discussion, was talking about, should you be asking drug companies really to do a phase 3 randomized trial in a rare population? And you also spoke about this during your talk about the Adams law, and that we should stop doing these huge randomized studies because you have to screen thousands and thousands to get those small sets of couple of 100 patients. And then with such super responses in the 2nd line, 3rd line, 15th line, should you be really asking, is it ethical to really do a trial when the responses are so good from a regulatory standpoint? I want you to take that question, and then we'll probably move to the next case. We're running short of time.
No, absolutely. I can give From the FDA point of view, the FDA gave a full approval to selpercatinib and pralsetinib based on the single arm study, based on the evidence from natural history of disease and RET fusions. So the companies are stuck mainly because although they get an approval in the US, most of the geographies don't approve drugs based on single arm studies.
Okay.
They have to go to multiple countries, EMA, Singapore, Japan, Australia, India. Many countries, they don't, they want a randomized study. Unless there is regulatory harmonization across the globe that can mirror FDA approvals, that can take, the data as is, especially in these biomarker-driven diseases, I think big pharma is going to be wanting to do these randomized studies. In fact, FDA did not want these randomized studies to be executed. Okay. And because, it's always good to have two drugs than one drug, because, these two are different drugs. Both are very good drugs, and I've used both these drugs in patients. I've used pralsetinib and selpercatinib in over, again, hundreds of patients, right? So again, each at least I would have treated personally 60 to 70 patients personally. Again, on both these drugs. Both these are very good drugs, with different unique side effect profiles. Some patients do tolerate this drug. Some patients do tolerate the other drug, right? Selpercatinib has LFT and hypersensitivity, whereas pralsetinib, you have patients presenting with low counts. So when one patient does not tolerate this drug, we can always go to that drug, or vice versa, right? So again, for oncologists, doesn't matter which drug. We want our patient to benefit from that drug.
Absolutely. And
tolerate the drug. It's always good to have one or two options, like BRAF, right? We have encorafenib, we have dabrafenib. We always switch back on these different options. It's like Coke, Pepsi, Diet Pepper. We keep changing these drugs. It's good to have more options for these patients. Again, we are stuck, right? If a patient develops a hypersensitivity reaction or a bad LFT from one drug, I don't want to go back to pemetrexed, which the patient progressed from.
Absolutely.
Right? So it's always good to have two options. Yeah.
And then the CNS, we don't have time to talk about it. The CNS protective effect of selpercatinib seems to be phenomenal. Second only to lorlatinib, though. But, it's simply superb. If you see the hazard ratios for CNS protection, it's 0.17, some phenomenal numbers, hazard ratios that you probably never saw earlier in oncology at all. So I think good time for our patients, challenging time for doctors, I would say, exactly what Dr. Christine was talking, during the course of her summary. So I'll stop here, Dr. Subbiah, and then we'll go to the next case. We'll probably talk 10 minutes on BRAF and then probably close. Vishwanath, back to your student.
Doctor, thank you, Dr. Senthil, for the wonderful moderation. Let's move on to the second case quickly. Dr. Nivedita, are you able to?
Yes, sir.
Yeah, okay.
Thank the organization for giving me this wonderful opportunity to present in this platform. So today I would like to present a case of BRAF mutated metastatic colorectal carcinoma. So this is about a 78-year-old male with a ECOG PS1. In November 2018, he was presented with bleeding PR and weight loss and constipation. So a colonoscopy was done, which showed a proliferative sigmoid growth, 12 centimeter from the anal verge, and it was causing luminal obstruction, and the scope was non-negotiable. Biopsy was taken, which showed histopathology was moderately differentiated adenocarcinoma, and the molecular test was also done, which showed KRAS, NRAS wild type, and a BRAF V600E mutant, HER2 wild type, and it was a MSS. So we done the other investigation, among which the hematological and the biochemical parameters were within normal limits. The 2D echo shows ejection fraction of 60%. The serum CEA level was 106 nanogram per ml, and the baseline PET-CT was done in December 2019, which showed a sigmoid colon mass with metastatic mesenteric lymph nodes with multiple metastasis in both lobes of liver and a left upper lobe mets. So it was diagnosed as a stage 4 colon carcinoma, and we took a surgical consultation also, which was deemed as unresectable. But the patient meanwhile, he developed some obstructive features. He developed acute onset pain abdomen with constipation and vomiting, for which he had to undergo a Hartmann's procedure with stoma in December 2018. And the patient was started on systemic therapy with Folfox and bevacizumab. So after 6 cycles of Folfox, with bevacizumab, the patient really had a good symptom control. His appetite improved and he had a weight gain by 4 kgs with the adverse effect of grade 2 diarrhea, grade 1 peripheral neuropathy, and grade 2 anemia. And response evaluation was done, which showed the CEA level reduced to 22 nanogram per ml, and PET-CT there was complete metabolic and morphological response. So we continued the treatment, and after 12 cycles of Folfox and bevacizumab, there was, from the clinical point of view, the patient was asymptomatic. There was a good serological response, and CEA came down to 8 nanogram per ml, and radiological response showed the PET-CT CMR was maintained, and at this time, the patient had grade 3 peripheral neuropathy, grade 2 anemia, grade 2 diarrhea, and grade 2 mucositis. So although we advised him to continue some maintenance therapy, but the patient preferred a drug holiday. He felt that he got cured of the disease and preferred to be off treatment, as he had already grade 3 pain and he had some personal commitments. So he remained off treatment for a brief period of time, and we kept him on regular follow-up. In December 2019, on follow-up, the CEA increased from 8 nanogram to 20. And he developed a new liver lesion in segment 5, for which a microwave ablation was done. And he was planned for second-line chemotherapy with FOLFIRI and bevacizumab. So it was planned that we will consider 6 cycles of FOLFIRI and bevacizumab, followed by a response evaluation. So a response evaluation was made in April 2020, which showed a good serological response, and the CEA came down to 20. And then we continued the treatment, and after completion of 12 cycles of FOLFIRI and bevacizumab, there was an increase in CEA from 6 nanogram to 135. So there was a serological progression at that time. So we did a radiological evaluation this time, and PET-CT was showing disease progression with multiple new onset liver mets, new onset adrenal mets, and left lung lesion. So we did a liquid biopsy, and it was found that a BRAF6 V600E mutation was found, and he was planned for dabrafenib and panitumumab. But meanwhile, before the treatment could be initiated, he had developed a cardiac event, and AMI happened, and for which he had to undergo intubation, and ECG was suggestive of a non-ST elevated MI. TROP-T came positive, and 2D echo was done, which showed regional wall motion abnormality, as well as the ejection fraction also dropped down to 55%. So a coronary angiography was done, which showed 90% block in the left anterior descending artery, for which he had to undergo coronary angioplasty, and he remained off of anti-cancer therapy till December 2020. So we did a PET-CT scan again in December 2020, which showed increased activity of the liver lesions, lung, and adrenal lesions. So it was a frank disease progression. So he was started on panitumumab and dabrafenib, and after 6 cycles of panitumumab and dabrafenib, there was a serological response with the CEA reduced from 194 to 130, and we did a PET-CT scan, which was suggestive of stable disease. At that time, he had some clinical benefit with the improvement of the symptoms. And this time, he had grade 3 mucositis and rashes with grade 2 diarrhea and grade 3 fatigue. So we continued the same treatment for 12 cycles. And PET-CT was again done in May 21, which showed again serological progression with CEA increased to 228. He developed a new liver lesion, and it was a FANG progression. So this time the patient's PS was deteriorated, and patient was symptomatic with a mild right upper abdominal pain, and we planned her for regorafenib. So presently she is on regorafenib and doing well with this. So this is my case, sir.
Thank you, Dr. Nivedita. Dr. Senthil, for your comments, moderation, and
nice case again. It narrates a nice story of what truly happens. But again, Chandrakant, your hands seem to be very lucky for patients. Typically you don't expect a BRAF mutated colon cancer to go on for, a couple of years, 3 years like this. But great for your patients. As you earlier said, sometimes we show our success stories in panel discussions, but even if it's one patient and he's done so well, we're still happy for your patient. Great. Let me start with Dr. Ramya. Dr. Ramya, what is your chemotherapy, doublet, triplet, bevacizumab, how do you approach your patients with a BRAF mutated colon cancer, stage 4 colon cancer?
We've had a couple of BRAF mutated colon cancers. So they phenotypically also seem to be more right-sided. They tend to have a lot of peritoneal disease. And I mean, I think a couple of patients whom I've seen have always had peritoneal disease, had intestinal obstruction. That is the way they have presented. Depending on the performance status, we go either with a doublet or a triplet plus bevacizumab. But there are first-line trials that are looking at the combination of encorafenib with FOLFOX, if I'm not wrong, but I'm not aware of the results of the trial. But the first-line trials, I think
You're right. It's called the breakwater. We just got some preliminary results from the study. You're absolutely right.
I'm not aware of the results, sir. So, but then
we don't have the results yet, Ramya. We just have some, the toxicity run-in results we have, and then based on that, the actual phase 3 has started. You're right. So, although most of us tend to push towards the triplet plus Bev, now there have been meta-analysis after meta-analysis that is clearly showing that except for better responses, we don't get better overall survival. So I was enthusiastic. I used to do a triplet, but now I've kind of toned down and I go to a doublet, exactly what Chandrakant has actually done. But yes, we all have our impressions on how to go about treating these patients. I'll come back to you, Dr. Subbiah. The first question is, when it comes to BRAF, it's very different in colon compared to all the other BRAF mutated places. You also showed response rates of 4% once, and then 12, 13% compared to 40, 50, 60% in lung cancer. So how is this different in colon cancer compared to all the other cancers? Is it because of the EGFR interaction that it has? The second question as a runoff from that is, MEK inhibition doesn't seem to make a big difference in colon cancer, while it seems to be making a big difference in all the other areas. So two questions there. One is, how different is it in colon? Why is that MEK is not making a big difference? It does make a small difference, but not a tangible difference for it to be approved in the second line as of now. Dr. Subbiah.
Oh, thank you so much for that question. In fact, when we started doing the studies, I was a new faculty at the time. We did not know that colorectal would not respond. We did the original vemurafenib basket study.
Right.
We call it the history. It was also published in the New England. The final results were published in Cancer Discovery. So we did not know that. No preclinical model predicted that colorectal cancer and melanoma would be different. But when we did the study, it was striking. Every cancer, cholangio, anaplastic, salivary gland, even pleomorphic xanthoastrocytoma were responding. Colorectal was not responding. Right? Although some patients, now that I think back, had stable disease even with single agent VEM for a long, long time. We were scratching our head at that time. We didn't know why. Right? Again, as clinicians, we didn't know why. Boom, we see a Nature paper at that time. Prahalad et al., Nature, published that EGFR is an innate, adaptive, intrinsic mechanism of resistance to BRAF, colorectal cancer. And immediately we are like, wow, okay. So we knew the trial was ongoing. We knew that we had a lot of patients being referred for this. So what we did was, cetuximab is approved in this setting. We added cetuximab to that clinical trial just for colorectal patients. And we started seeing responses. We started seeing patients at least benefiting from vemurafenib cetuximab combinations in colorectal. And this resistance operating mechanism was not seen in any other cancer than colorectal cancer. Even in colorectal cancer, I should say, the response is not 0%. Some patients still do respond.
Yes.
Right? And one thing also to note, if you think about colorectal cancer, response rate, RECIST-based response rate may not be the best measure of success in colorectal cancer. If you see the two drugs that have been approved in colorectal cancer, regorafenib, right? Not my favorite drug, but still it got approved.
Nobody's favorite, it looks like.
Right? Again, not my favorite drug. Again, these are challenging drugs, right? Patients do not tolerate it as well.
Correct.
Right? Both of them got approved, right? Again, these are options, right? We have options for our patients. So the response rate to Lonsurf is 1%. Regorafenib is again 1%, right? So again, response rates may not be a marker endpoint in colorectal cancer. Having said that, the EGFR as an operating mechanism of resistance is seen mainly in colorectal cancer. And we are learning a lot, right? From the subsequent studies, what we learned was MEK inhibition may not be as needed, right? Although it can contribute a little bit, if it contributes, say, 30 to 40% in other tumor types, it's contributing 10% in this, right?
Right.
But, when we combine 3 different agents, is it necessary to give an agent with added toxicity, right? So that, we've had a debate going back and forth in multiple meetings. There are 2 schools of thought in that. One is, hey, by the way, with single agent BRAF inhibitors, monotherapy, and combination with cetuximab, with BRAF inhibitors, you could get, the squamous cell carcinomas and basal cell carcinomas of the skin, right? Because you have paradoxical activation of the MAP kinase pathway. So MEK inhibitors can mitigate that. It's not just about the response rates. The MEK inhibitors can mitigate that, right? Can prevent, delay a progression of resistance. So again, when we are in some meetings, there are some debates saying that, hey, MEK inhibitor can prevent the secondary malignancy in those patients from happening, right? So it may not be for the responses, but at least to prevent those secondary malignancies. But others are like, hey, MEK inhibition is not easy drug. It's not like, Crocin or Tylenol, right? So it comes with its own liabilities. You get rash, you get eye toxicities, bad eye toxicities, patients don't tolerate, and these drugs are expensive.
That's right.
It's not like metformin or anything, right? These drugs are expensive. So the challenge is when you add more drugs, you need to add the toxicity, the cost, the, everything together, right? Overall benefit versus a risk profile. I think that is mainly one of the reasons why MEK is not being added in the combinations, right? In an ideal world, you put up more drugs together, you will have higher response rates. Patients are going to be on, therapies together. We can talk about this for a long, long time.
Absolutely.
Right. So again, but the main thing is that, right, one thing before I finish, one thing right now they are also doing this, a combined PD-1 BRAF MEK inhibitor in colorectal. A phase 2 study was published by David Ryan and Ryan Cochran and recently in Nature Medicine, right? So that shows a nice response rate even in MSS colorectal cancer with BRAF mutations with immunotherapy. It's a chemo-free regimen. They wanted to do away with chemotherapy. We'll see how that data reads out. And that'll be interesting to see if we can get a frontline chemo-free regimen in patients with colorectal cancer. Maybe those subset of patients who can benefit from PD-1 and the triplet combination can continue without chemo.
Correct. So you're absolutely right in terms of the thought process, which is what reflects in most of the literature that's there on BRAF, which clearly says that in colon, it's very different. But if you look at the resistance mechanisms in the biomarker study of the Beacon trial, for the doublet, most of the bypass mechanisms of resistance seem to be MAP kinase mediated. And very interestingly, as you rightly pointed out, the incremental benefit of doing a MEK inhibitor as part of the triplet did not make a huge difference. Response rates went up by some 4-5%. And as you rightly said, the irinotecan and cetuximab response rate was 1.4%, a phenomenal 1.4%. So it just tells you that the PFS is just a couple of months. I don't see any big reason to put these patients on chemo in the second line. Though again, Chandrakant's patients did very well. The literature says it's 1.5 months of PFS, while Chandrakant went on for many months. But that's great. Again, biomarker study, Dr. Subbiah, they looked at RNF43, right? And those patients who had an RNF43 mutation seem to be doing better on the combination compared to patients who don't. So do you think in the near future we'll have some co-mutations which will predict better efficacy of these, or we're kind of plateauing off somewhere?
I think definitely co-mutations do have an impact, right? RNF43 is driven by, it's a Wnt signaling pathway.
Right.
And Wnt signaling is itself interesting in colorectal cancer, right? Because I think we had like many Wnt inhibitor, Pakapin inhibitor studies. They didn't pan out in colorectal, although the pathway is active, because what we see is these are early events, like APC mutation. Wnt is an early event in the progression of colorectal cancer. And when we are seeing them, we see these patients 5 years, 10 years from where the signaling process started, when the mutations happened to these, RNF43 mutations happened maybe 5 years, 10 years ago. in that, in that cell, and we are seeing them 5 years out where something else is a driver. So there is definitely an impact of these mutations. But again, these are early data. We will see what it shows. Again, but my thing, I'm looking really forward for a chemo-free regimen in the front line.
That's right.
We'll see how it pans out. Yeah.
That's right. That trial is really on. So we're looking forward to the breakwater, and the other, the name Crossmark, that's called. That's the second study where people are looking at PD-1 inhibitor plus the doublet. Breakwater, very interestingly, irinotecan is not part of the combination because there is interaction between irinotecan and the BRAF inhibitor. So the irinotecan level seems to be going down by 25%. So that's the safety run-in part based on which we came to know. But the responses seem to be superb. It's at 68, 70% for the chemo plus the doublet combination compared to chemotherapy alone. So I think that's a space that we need to watch because this is an area where we're just stuck. Last question before we let you go, Dr. Subbiah. You see that about 20 to 30% of patients with BRAF will also have an MSI high. We did speak about it, right-sided colon. So how do you approach these patients in the first line? Should you be chasing the BRAF or should you be chasing the MSI? Because it looks to be from at least the biomarker studies that MSI is the way to chase at least in the first line, and then look at the BRAF in the second line. What are your thoughts on that?
I think that's a great question. So I'd say, like, you think about the immunotherapy, right? Immunotherapy, if it works for a long time.
Right.
BRAF, tyrosine, are like any other tyrosine kinases, although we are buoyed by the thrill of success, universally, they develop resistance mechanisms in 4 to 6 months. So again, if a patient starts to respond to immunotherapy, the response is for a longer time. So I would prioritize immunotherapy in a patient with MSI high, right? Again, given that MSI high patients have like 50, 60 mutations always, like BRAF is just one of them, right? So I don't know if there are trials combining immunotherapy with BRAF. We'll see if those patients have a better benefit, right? That's one. Number two is, although we have encorafenib, vemurafenib, dabrafenib for BRAF, right? Again, these are like first generation agents. Right now in clinic, we have different classes of agents for BRAF targeting the MAP kinase pathway. We have belafenib, tovarafenib, we have a kinase drug, we have a Pfizer drug, we have better drugs because with AI, we have better class of drugs being designed in the space. We have even BRAF degraders. We will see how these can impact, colorectal cancer, BRAF, and other BRAF cancers. Again, we have become in the 2023 drug development is different from 2012 drug development because the drugs we are working on is those drugs that were designed by humans by conventional drug screening. AI is able to dream these drugs, degraders, these alpha-fold 2 based new proteins that are able to eliminate or degrade protein. So we will see how the next decade is going to help us with these drugs. We may not need all these therapies. I'm hopeful, right? As a clinical trial, we are always hopeful for a one drug, that can eliminate all this. We always remain hopeful for that drug, like a BRAF degrader that can eliminate the entire BRAF protein, so that we don't need to worry about all these combinations.
That's right. Thanks you so much, Dr. Subbiah, for being very patient and taking all our questions. We're 20 minutes beyond the scheduled time, but still you were able to stay on with us and then answer all our questions. I'm sure in the future with AI, good drugs, and more importantly, brilliant researchers like you, times ahead seem to be really bright. And we hope to interact more often with you, learn better, and be better oncologists, should I say. Thanks, Chandrakant, so much. I'm handing it over back to Vishwanath.
Thank you, sir. Wonderful listening. Thank you, sir.
Thanks so much. Thank you so much. Pleasure.
Over to you, Dr. Santosh, for some closing remarks.
Thank you, sir, Dr. Senthil, for that wonderful moderation. It was super interactive and one of the most interactive sessions we had with the CPOM ASCO endorsed webinar series that we have had. This is the last of the year of the CPOM ASCO webinars. We thank ASCO for being part of these webinars. I think Sarah is still here with us. We thank Dr. Senthil, Dr. Christine Lowley for chairing the sessions, Dr. Vivek Subbiah for the superb talk on his birthday. Dr. Ramya Anathakrishnan for filling in for Dr. T. Raja, and she did a equally good job with her presentation. Dr. Preetham Sarkar and Dr. Nivedita Sen for the case presentations. Thank Dr. Chandrakant, Dr. Poonam Maurya, and Dr. Rachan Shetty, who are the co-organizers for these webinars that we have been doing. And we, last but not the least, sponsors Core Diagnostics, Newburgh Anand Labs, Dr. Lalpat Labs, and 4Base Care Labs for the educational grants. And have a good weekend. Thanks, one and all.
Thank you.
Good night.
Thank you. Bye-bye.